Bismillah ar-Rahman ar-Rahim. I would like to welcome you all to this is the third pathology workshop in Bahia conference. And I would like to introduce to you all Professor Dr. Abir Shaban. She is a consultant pathologist at Queen Elizabeth Hospital, Birmingham, UK. She has led a number of research, and she has over 160 research publications. Actually, we are very honored to have you today with us. So the mic is with you.
Thank you. Thank you, Dr. Gada, for the kind introduction. It's a pleasure to be with my colleagues, and it's a nice pathology meeting, so we can talk proper pathology. And I was asked to talk about an update on lobular neoplasia of the breast. So when we say lobular neoplasia, we mean a range of changes from atypical lobular hyperplasia, or ALH, to lobular carcinoma in situ. And LCIS can also be divided into classical LCIS and other variants. So just to summarize before we start, classical LCIS, the standard that we know, expansion of the terminal duct lobular units by the characteristic discohesive lobular cells. Some of them can have very scanty cytoplasm, and some can have more cytoplasm, but the main feature is the discohesion. On the other end, we have what we call pleomorphic LCIS, or PLCIS. This is a high-grade disease, very similar to high-grade DCIS, can be associated with comedonecrosis and calcification, but this is not a prerequisite. We diagnose it based on the high-grade nuclear atypia. In between, you have these florid LCIS, which comprises cells similar to classic LCIS, but expands large ducts and also can be associated with comedonecrosis and calcification, and therefore can be detected mammographically. So far, the management of LCIS generally in the US, in Europe, and in the UK is done by what we call second-line VAP, or vacuum-assisted excision. Previously, in the old times, we used to excise these, but we no longer do that. And this is the papers that we follow in the UK of the management of B3 lesions, which recommend classic LCIS to be treated by second-line VAP or vacuum excision. And this is another copy from the radiology guidelines in the UK, again detailing all the B3 lesions, including atypical lobular hyperplasia and LCIS, the risk of upgrade to cancer, and the recommendation. And after that, we follow up annually for 5 years in the symptomatic setting. Just to recap, our core biopsies that we receive as pathologists range from the standard or conventional core biopsy, which is the 14-gauge needle, which is what we use for mass lesions, diagnosis of invasive cancer. And then you have the mammotome, which is a vacuum-assisted biopsy, which is used for first-line VAP. And first-line VAP is a diagnostic procedure. So not a lot of tissue is removed, but a larger core needle. Then ending up with vacuum-assisted excision, which is a bigger one, usually 8-gauge or 7-gauge needle. I talked about the UK guidelines, but other international guidelines, including the European or Swiss guidelines, recommend the same. And they arrived at the conclusions in a different way by voting basically among experts. They, in other areas, differ from the UK. For example, if you diagnose ADH, they recommend excision, while we would do vacuum excision. And there are other lesions that they would recommend excision, as we do, like Phyllodes tumor. So just this is for your information about the European guidelines. The latest AGCC cancer staging guidelines and the TNM, they actually removed LCIS completely from staging, and they do not consider it as in situ disease. Even PLCIS, which is a pleomorphic type, is not diagnosed as in situ disease anymore. We don't follow that in the UK. We still regard high-grade PLCIS as in situ disease. However, the consensus is that for the high-grade lesions, we would excise. So the WHO book would say that, and PLCIS is managed as per high-grade DCIS. So classic LCIS is usually a disease of premenopausal women, can be multifocal and bilateral. The true incidence is low, but ranging from 0.5 to 3.8%. Long believed to be a marker of increased breast cancer risk, but now more recently we think it is a direct precursor for invasive lobular carcinoma because it shares the same molecular profile and it has the same mutation of the ECADHERIN gene. Histologically, as we all know, discohesive monomorphic proliferation, usually with some intracytoplasmic vacuole, and pagetoid spread can be seen. Really important to emphasize that the cells of classic LCIS comprise two types, type A cells and type B cells. So type A cells, these are the very monomorphic, almost lymphocyte-like cells with very little cytoplasm. While type B cell is a more difficult one, where you have more cytoplasm and more variability in size and shape, and this is the one that should be differentiated from pleomorphic LCIS. Pagetoid spread, as we know, can be seen with lobulars, where you have a compressed luminal layer and a myoepithelial layer, and in between them, the lobular cells are there. How to differentiate ALH from LCIS? It's a quantitative definition. So LCIS is diagnosed when more than half of the acini are filled, distended, and distorted by the characteristic lobular cells. On core biopsy, it doesn't really matter what to call it. So we tend to use the terminology lobular in situ neoplasia to encompass both. Both are B3, both are managed the same. So whether you think it's ALH or LCIS, on a core biopsy really doesn't matter, but on the excision, try to make the distinction. And this is an example of ALH rather than LCIS. So on core biopsy, the UK guidelines would call them lobular in situ neoplasia, designate as B3, and recommend vacuum-assisted excision. Immunohistochemistry, as we know, ECADHERIN is usually negative, but remember that it doesn't have to be completely negative. You can get a bit of heterogeneity, you can get a bit of cytoplasmic expression, so don't expect complete absence in all cases. Basal cytokeratin, CK514, are usually negative. ER is almost always strongly and uniformly positive in classic LCIS. HER2 is negative. One marker that's useful, if you think it's LCIS, you did ECADHERIN, it looks positive. You can do beta-catenin as well. And beta-catenin has the same expression as ECADHERIN. It should be negative, and it can be helpful in difficult cases. You can also use a marker called P120, and then you get cytoplasmic expression. And this all indicates an ECADHERIN complex that is dysfunctional. So this is an example of ECADHERIN confirming pagetoid spread in case of lobular neoplasia. Sometimes you get a combination of ductal and lobular carcinoma in situ. So on the right side, this is ECADHERIN positive DCIS. On the left side, this is LCIS. And the ECADHERIN stains the luminal cells and also myoepithelial cells. And this is a useful internal control to indicate that it has worked. So you see the myoepithelial cells are always there, indicating that it has actually worked. CK14 is negative, and again this highlights the pagetoid spread here. And classic LCIS is a part of what we call low nuclear grade neoplasia family, or what Rosen called Rosen's triad. So you get columnar cell change, including FEA, tubular carcinoma, low grade invasive ductal, and low grade DCIS. So you can get them together. So if you find one, look for the others. If we move to pleomorphic LCIS, so it is lobular. By definition, ECADHERIN negative, discohesive, the same type of cells. However, the nuclear grade is high grade. So if you think this is DCIS, you would call it high grade DCIS. So grade 3 nuclei, pleomorphic cells. You don't have to have necrosis, you don't have to have calcification. It's just a nuclear grade. So it's a more recently recognized variant of lobular carcinoma in situ, commonly calcifies, Biology has always been uncertain, and histologically it mimics high-grade DCIS. So that's what it looks like. On low power, solid proliferation, that's really important. Solid proliferation of cells with necrosis and calcification. So at this power, it looks very much like DCIS. But you go higher, you see the eccentric nuclei, some vacuoles, and you have this discohesion. Cells have lost contact with each other. So that's when you think it's lobular and do your E-cadherin, and this should prove it. This is another example, more pleomorphic and more apocrine looking cells. So apocrine pleomorphic LCIS is another subtype where you get apocrine morphology, high-grade nuclei. Again, look for discohesion. That's the first clue. The second clue actually is a purely solid appearance. If you have solid proliferation, you don't have cribriform pattern, you don't have micropapillary, it's all solid, always think lobular. Could it be lobular or is it ductal? Pleomorphic apocrine LCIS is a subtype of LCIS. Again, pleomorphic apocrine nuclei, so the differential is your high-grade apocrine DCIS. And this is what it looks like. So this is one of our cases, clearly high-grade, lots of mitoses, but can you see this discohesion there? So that's when we think, could it be lobular, and prove it by E-cadherin. The location doesn't help you. So lobular neoplasia can involve larger ducts, and DCIS can also involve lobules. So whether it is in a lobule or not doesn't really help. It is the morphology that you're relying on. PLCIS is E-cadherin and beta-catenin negative, similar to classic LCIS. What's different is that estrogen receptor may be negative. So if you have a lobular proliferation that is ER negative, it's very unlikely that this is classical. Think of the other types, okay? Again, gross cystic disease fluid protein and GATA3 are normally positive because of the apocrine morphology. Again, HER2 may be positive. The majority of PLCIS cases would be ER positive, HER2 negative, but a small proportion can be ER negative, HER2 positive, and that is helpful. So this is pleomorphic LCIS, that's E-cadherin negative, and this is PLCIS, that's ER positive. This is a nice case of an example of classic LCIS with superimposed pleomorphic LCIS. The classic LCIS is strongly positive for ER, and the PLCIS is negative. So you can actually use these markers to differentiate in difficult cases, and it's not uncommon to have a spectrum of changes. So you have a bit of background of classic LCIS, you're really not sure, is this the cutoff, do I have PLCIS or not? And you can do some of these markers to help. Helpful, obviously, if ER negative. And this is an example of HER2 immunohistochemistry. Classic LCIS is almost negative, and the PLCIS is positive. So I do use these as well in difficult cases. This is one of our studies of pleomorphic LCIS, which is a large UK multi-center audit of PLCIS. We collected 179 cases. The mean age at diagnosis was 60, which is slightly older than DCIS, or more similar to DCIS and older than classic LCIS. The associated cancers were predominantly lobular, and a small proportion were grade 3 and ER, mostly were ER positive, HER2 negative. If you have pleomorphic LCIS in core biopsy, when we did further tissue examination, we upgraded to invasive malignancy in almost a third of the cases. So this is in situ disease, and once we diagnose it on core, we need to excise. It's B5A, okay? So classic is B3, PLCIS is B5A, managed by complete excision as per high-grade DCIS. So what about the one in the middle? That's the most recently described type, which is called florid LCIS. And this is the latest WHO 2019 definition. So the essential criteria are classic LCIS. And when we say classic, this means type A or type B. It's not high grade. It's really important. It's not high grade nuclei. which involves large ducts, and they define large ducts by the presence of 40 to 50 cells within the duct or very little stroma in between. So basically, you have big ducts distended by this. Desirable to show that this is ECADHERIN negative. That's what it looks like morphologically. Very similar to low and intermediate grade DCIS, but not high grade. If you think it's high grade, that's PLCIS, okay? So big ducts, very little stroma. Definitely we have more than 40 to 50 cells. You can get associated calcification in the bottom half here and necrosis, but the cells are low grade. This is another example which looks almost like a mass, and this in the previous literature was also called mass-forming LCIS, because it can look like very, very little stroma can represent with a mass lesion. But again, the cytological atypia is low grade. This is one here that's associated with invasive lobular carcinoma, and it can be associated with a background of classic LCIS as well. Another example, again, note the low-grade nuclei, and this is associated with calcification here. To prove that it is lobular, you do ECADHERIN, but I think that the clue is to think about it, to consider it, because if you don't, you'll call it DCIS. So just think about it, particularly if you have a solid proliferation. You don't have any other architecture. So consider it when you have solid low-grade in situ proliferation, look for discohesion, intracytoplasmic vacuoles, and do ECADHERIN. So what do we know about florid LCIS in core biopsies? Obviously, it's a rare disease, even rarer than PLCIS, so we don't have big series of it. But what we have so far indicates that it is biologically more aggressive than classic LCIS, probably less than pleomorphic LCIS. Most studies, included our own, shows an upgrade to in situ or invasive malignancy in about a third to a half of the cases. So it is clearly high-risk lesion, and it's likely a precursor as well of invasive lobula. How do we manage florid LCIS? So far, no standardized guidelines. So if you read the WHO book, the TNM and so on, it doesn't really tell you in detail. However, we manage it as per low and intermediate grade DCIs. That's the consensus view now. So in the UK, if it is pure on core biopsy, we call it B4, which is suspicious for malignancy. So we put it somewhere between classic and pleomorphic LCIS. But we would recommend excision, full excision with clear margin. In Europe, the European guidelines would call it B5A. So they would just regard it as DCIS, low grade, and again recommend excision with clear margin. So the current state of knowledge, although we don't have enough data, is to perform excision and clear the margin as much as possible. The association with malignancy and the rate of upgrade indicates that it's more aggressive than classic LCIS. So if it is at the margin, as in this case, we would go back and clear the margin, do a cavity. And this is a really nice paper on the preoperative management of pleomorphic and florid LCIS. And sometimes it's difficult in the literature to dissect florid LCIS on its own, because as in this paper, they lumped it with PLCIS together. So there are few series on florid on its own. So they combined florid and pleomorphic LCIS, total of 117 cases, which is a reasonable number. We found that there is associated DCIS or invasive disease in 2/3 of the cases. And the underestimation of malignancy was almost 40%. And they also did literature review, which found the upgrade was 65% and the underestimation of malignancy about 34%. So around this figure. So this indicates that it is an aggressive disease. So just to summarize the upgrade rate of lobular neoplasia, the classic LCIS is around 27%, and that's why we would sample more. We wouldn't leave LCIS. We would sample by vacuum-assisted excision for the classic one. For pleomorphic LCIS, around 41%, but a wide range as per this paper. So the risk of upgrade to malignancy after a core biopsy diagnosis. This is a very recent systematic review and meta-analysis of this, looking at 65 full-text articles. They found that the risk of malignancy after diagnosing LCIS is quite wide, from 0, some studies said no upgrade at all, and some up to 45%. And as you see, the risk for upgrade to invasive malignancy was in this was small, and there is a risk associated with ALH as well. So how about the management of pleomorphic LCIS? Again, a nice study from the UK looking at previous studies with level 3 to 4 evidence, and they have looked at the guidelines. So NCCN guidelines would say if it is PLCIS, excise with negative margins, same in the UK, ESMO. So all the consensus for PLCIS is treat as high-grade DCIS. And they can even recommend sentinel lymph node biopsy if extensive calcification. That's why it makes it really odd, an anomaly in the TNM system, that this is not regarded as in situ disease, and that's why we don't follow it in the UK. We would just call it DCIS. We also include it in the whole tumor size, and we also measure it to the margin. So we basically treat it as DCIS. So we covered that. Practical points for LCIS. The WHO book does not recommend the use of these terminologies. So we really need to specify what it is. Is it classic? Is it florid? Is it is it pleomorphic? Don't use the generic term non-classical LCIS. Doesn't help. Which one? So, and don't use variant LCIS. That's not accurate. So these are obsolete ones now. We don't use them. Marker clips, as we heard earlier, very helpful if you sampled an area of what you think is B3 or atypia. So put a marker clip, because when you go back to do vacuum-assisted excision, you would sample or target the area of the marker clip. So we actually use this quite a lot in the context of the B3 lesions. And interestingly, the marker clip histologically depends on the type that your radiologist has used. And there are several types of marker clips. So this is one type that has this mesh-like appearance with foreign body joint cell reaction. This looks like more cystic. And this is a cavity that you can see if you, after second-line VAB, you go for a diagnostic excision. You can tell that this is the area that was biopsied. So when you know what your radiologist is using, you will get used, and you will get your eye used to the type of clip used. So what's the differential diagnosis of LCIS? Depending on which type. So classic LCIS can be differentiated from solid low-grade DCIS. PLCIS mainly from high-grade DCIS, and if it is the apocrine type of PLCIS, the differential is apocrine high-grade DCIS. Sometimes LCIS involves a structured lesion, like a papilloma, like sclerosing lesion, sclerosing adenosis, can look very similar to invasive disease. So pay attention to the pre-existing lesion and do your myoepithelial immunohistochemistry to highlight that it is there and it's not invasive disease. And these are some of the very recent publications from the UK and mainly actually in the UK, on the management of B3 lesion, reviews on B3, a bit of practical hands-on tips for management of B3 lesions and LCIS in your leisure. And just to say that we are involved now in an updated international guidelines, the EORTIC, ESO, ESMO coming together to provide multidisciplinary B3 guidelines for everybody. So not only, you will see some differences in management between the UK guidelines, European guidelines, American guidelines. So we are putting this together, and this is being developed. So there will be a unified evidence-based guidance for management of B3 lesions, including lobular neoplasia. Hopefully, these should be finalized by end of this year, beginning of next year. Thank you.
Thank you, Dr. Abir, for your comprehensive and fruitful presentation. So, any question?
Can I have a question?
Yeah.
Yeah, thank you for your lecture. In fact, these are very early lesions, sometimes small, sometimes medium, but generally they are not clinically manifest as masses. So how can one be sure of the adequacy of the biopsy, and what are the guidelines for its adequacy?
Yeah, very, very important point. Most of these lesions will be diagnosed during mammographic screening. So if you're doing screening mammograms for calcification or so, that's when you will find lobular neoplasia. And sometimes lobular neoplasia, particularly ALH, is found as an incidental lesion. So you might be sampling like a cyst or something else, completely benign, or even a fibroadenoma, and you find superimposed lobular neoplasia on top of it. So usually incidental or in the context of calcification. The literature says that classic LCIS doesn't normally calcify, but we see calcification within even classic LCIS. So usually during mammography, or as you said, as incidental lesion. Management is exactly the same, whether it is incidental or associated with calcification. Because even if you find it as incidental finding, the rate of upgrade in the literature is very similar. So we would still do second-line VAP.
Thank you.
Any other question?
Abir, thank you very much. Are there ultrasound or mammographic features that can favor lobular breast carcinoma?
Lobular invasive or in situ?
Yes, invasion, yes.
Usually the invasive radiologically is a bit ill-defined, usually a very ill-defined lesion, sometimes suspicious, but sometimes actually it's not that suspicious. So usually R3 or U3. So usually irregular, but it is more obvious by obviously MRI, and that's why if we do it and we find that it is the core biopsy is invasive lobular, we would do MRI, which is more accurate and would get us any other foci of multiplicity of bilaterality. For the in situ, there isn't anything that's specific apart from the calcification. Worrying calcifications that we would biopsy for are increasing calcifications, so calcifications that increase from the previous screen, new calcification, or calcification that is pleomorphic or follows linear distribution, because it would be within ducts.
Thank you so much.
Dr. Abir, is there a risk? How much is the risk of developing invasive cancer in pleomorphic lobular or classic lobular in situ?
Yeah, the data in the literature is quite wide and variable, but in the consensus is that with classic, the upgrade into cancer is about 25%. So about a quarter of the cases will be upgraded on further sampling. While in PLCIS, up to 60% can be upgraded, so 50 to 60%. Florid LCIS is usually in between, about 30%. So there is an upgrade, and that's why we would sample them all. But because the risk is lower for classic, we do only second-line VAP, but it's much higher for florid and PLCIS, so that's why we would excise.
Okay, thank you. Any other question?
Lesions from each other, or we can just see the discohesive cells with eccentric nuclei and full stop.
Yeah, in fact, we don't use fine needle aspiration for primary diagnosis of breast cancer at all in the screening situation. You sometimes get that when you FNA axillary lymph node. And that's when we can say, yes, it is malignant.
This is cancer.
Exactly. It is discohesive. It's likely lobular. But we always rely on core biopsy for diagnosing breast cancer. FNA has been obsolete in the screening program for decades now in the UK. So we only use it for the FNA, for example, of a cyst or for axillary sampling. And the UK is probably 50-50 divide. 50% of us do axillary lymph node biopsy, and 50% still do FNA because our radiologists are quite experienced and it's quicker for them.
What if it was an incidental finding?
Even if it is an incidental finding, we would, so if we think that we did FNA for whatever reason and we think there are lobular cells is malignant, we'd go back and do core biopsy for confirmation. Because this gives you the architecture. You can tell whether it's in situ or invasive, and also gives you the receptors, ER, PR, and HER2, which are mandated as well.
Agree, totally. Thank you very much. Thank you very much.
Yes. No, normally we don't, unless it is requested. We sometimes do it to confirm the diagnosis, to confirm that it is atypical. So if you have a proliferation, so the question was whether we do ER for lobular in situ neoplasia if diagnosed on core. Sometimes you maybe you're not sure if it is atypical or not. So if you have solid in situ proliferation, you think it's atypical, we do ER and we do CK14 or CK56. If it is strongly positive for ER and CK14 negative, then that's neoplastic. So we know that. But there isn't, we don't do it for therapeutic purposes because it's not requested by our oncologists.
Are there any roles for Ki67 in distinguishing cutoff values?
Yeah, I wish this would have been nice to have something to help, really. But when you do Ki67, there is a lot of overlap between PLCIS, florid, and classic. So there isn't a cutoff value to separate them, unfortunately. You're on your own. It's just morphology and your immunos if they help.
Any more questions? It's getting very exciting. Okay? Thank you, Dr. Abir. And it's my pleasure to introduce to you Dr. Mohammed Zakou. He's a lecturer of pathology at the National Cancer Institute of Cairo University, and he is a consultant in Bahia Cancer Center, and he is going to give us a talk on the multiplex immunophenotyping of a microenvironment in breast cancer. Please, Dr. Mohammed.
Thank you. Thank you for the introduction, Dr. Abir and Dr. Nadia. Dr. Gheda, sorry. It's a pleasure to be here, and actually the work I am going to present today was supervised and mentored by Dr. Abir, so I'd like to thank her so much. Our talk is about multiplex immunophenotyping of breast cancer tumor microenvironment. This work has been conducted in the University of Birmingham, Queen Elizabeth Hospital, Birmingham, and the Institute of Translational Medicine. To go to the point, I will not talk about the prognostic factors of breast cancer, but we are talking about an entity that has been as a predictive and prognostic biomarker, the tumor microenvironment immune cells. Tumor cells don't live and thrive in isolation. They are surrounded by various other cells with which they constantly interact, creating a unique environment, the tumor microenvironment. Breast cancer has long been thought to be not immunologically active. However, many studies have concluded that TILs and other infiltrates are present, TILs for tumor-infiltrating lymphocytes. Pre-treatment TILs can predict response to therapy and improve the prognosis, and therapy as the immunotherapy currently now implemented like the PD-L1. It is not only the amount of lymphocytic infiltration, but also the phenotype would affect the outcome. The cells that we have examined, we have delineated the CD4 positive T helper cells, CD8 positive cytotoxic T lymphocytes, tumor-associated macrophages, T regulatory cells, and B cells. This next video is, could you please, voice?
Killer cells, or NK cells, sense stress-associated molecules on damaged and cancerous cells. Dendritic cells, or DCs, activate cytotoxic T cells, which can then sense tumor-associated antigens using their T cell receptor and other co-receptors. Once activated, NK cells and cytotoxic T cells release perforin and granzymes. These molecules punch holes in the surface of the tumor cells, causing them to die by apoptosis. Helper T cells support these responses. They help DCs to activate cytotoxic T cells, and they produce cytokines such as interferon gamma that recruit and activate more NK cells. As the tumor evolves, genetic changes occur that can give some tumor cells a survival advantage. This means tumors are often heterogeneous. For instance, tumor cells may no longer express the molecules that are sensed by the killer immune cells. As the immune system continues to kill the tumor cells it can recognize, the cells it can't sense become more prevalent. This is immunoediting. It leads to the emergence of a tumor that can't be detected by the immune system. Some tumor cells actively suppress T cells by expressing inhibitory molecules such as PD-L1. PD-L1 binds to the PD-1 receptor on T cells and deactivates them. This is an immune checkpoint. In addition, tumor cells can attract immune cells that suppress the activity of other immune cells, thereby supporting tumor growth. These immunosuppressive cells include regulatory T cells and certain types of myeloid cells. They are continuously monitoring our tissues.
Okay, I think it has been repeated. In this summary, we have shown that the good cells that give a good immunity are the T helper and the B cells, which activate the cytotoxic T cells, which are the main mediators of the immune system, killing the cancer cells. But for the tumor-associated macrophages, there are two types, and the bad type, the cancer cells recruit the tumor-associated macrophages, and in return, they suppress the immune system by producing inhibitory cytokines. The T regulatory cells, as mentioned in the video, T regulatory cells, normally they suppress excessive immune response to suppress collateral damage in autoimmune diseases. However, in this case, in the cancer cells, it helps establish a good environment for the cancer cells. The purpose of our study was to analyze the counts, percentage, and densities of various immune cells in tumor microenvironment and determine their relationship to different clinical pathologic variables and the patient overall survival. Sections were stained for, as we mentioned, CD4, CD8, 20, 68, and FOXP3, as well as cytokeratin, using multiplex immunofluorescence, which allows simultaneous application of different markers and examining them on just one slide. We have selected patients diagnosed between 2000 and 2016 to allow for at least 5 years period of follow-up. We have identified 749, 47 of them were in situ, and the invasive ones were 702. And from them, the ones with available excision blocks were 144, from which we have constructed a tissue microarray. And this is the actual machine. It's a very simple instrument. It's from Breacher Instruments. The idea is very simple, that I have a donor block, which is, for example, the breast cancer case, and I have the recipient block, which is a blank wax block. And by the red needle, I take out a core of wax, and then by the blue one, I take a core from the donor block and put it back in the punched out place. And this is actual, as you can see here, if it's this tip is the tip of the core that I have taken from the donor block, and here I put it in the place that I have punched out before by the red needle from the recipient block. And this is how I start, by just 5 to 6 cores, and this is after it has been completed. And this frame contains 144 punches or cores, and we made our cases in duplicates. So every case was in this block was presented by 2, as here. These blue lines are called firewalls because of the artifacts that might happen during staining. even in the usual or the routine use, you are trying to count or evaluate away from the outer surface of the section. And this is the corresponding H&E slide. And then this is after being immunostained using multiplex immunofluorescence. Okay, the main method after we have these slides, after have been multiplex immunostained, and the whole slides were then scanned to be analyzed, to be further analyzed by the image analysis software. We have used 3 softwares, all are from Acquia Biosciences: PhenoChart, Inform, and Phenopter Reports. We will go through these steps, and this is the H&E section after being scanned and uploaded to the digital platform. And this is an image from the PhenoChart software, which functions to review the tissue quality of staining and the image quality, and the PhenoChart as well. It's here where we choose the fields that will be further analyzed. For example, I am not outlining this firewall, and in between we usually use normal tissues like brain, kidney, liver. So it helps the inside firewall or the inside skeleton helps to maintain the orientation of the block. This is an example of one of the punched out cores, or the cores of the TMA, and this is after it has been stained by multiplex immunofluorescence. And in this one, it has been transferred to the Inform software. And the first one, it's called image preparation, where if we compare with the other one, you will find that there is something like a gray background. This is the autofluorescence. So in this one, this has been subtracted and the colors were applied. Then training the tissue segmenter, which is machine learning aided program, you teach the software that, for example, this area is tumor, this area is stroma, and this, we repeat this many times till the software, we find it has done its best to delineate these tissues. And then this is the cell segmentation. So we actually, the main marker to delineate the nuclei is the DAPI stain, and this is the phenotyping. We train as well in this one. We train the software that, for example, this is a cytokeratin one, the pink one, the green one. We use them individually on the software. And this is after applying both tissue segmentation and cells and phenotyping map. This is how the raw image looks. It's repeating for the further one, and this is how the end result happens. Cells were phenotyped individually and then categorized as T helper cells are the cells that were positive for both CD4 and FOXP3. T reg cells, T regulatory cells, are the ones that are CD4 positive, FOXP3 negative. Cytotoxic are CD8, B cell CD20, and tumor-associated macrophages CD68. Individual and total cell counts in each compartment, I mean in the stroma, in the tumor, and in total were all analyzed and calculated, and then correlated with the different clinical pathologic parameters as well as overall survival. This is a closer look. The green ones represent the T helper cells, which are CD4 positive and FOXP3 negative. This cyan one is CD4 positive and FOXP3 positive Treg cells. CD68, the purple color, is the macrophage. CD20, the B cell, and CD8, the cytotoxic T cells. Our first we have examined to find what is the dominant phenotype, immunophenotype in each of the cases. And we have found that the CD4 T helper cells were the dominant immunophenotype in nearly 71% of the cases. This large, like 3/4, followed by CD8, followed by actually CD20 and then CD8. And this is an example of a CD4 positive dominant, a T helper positive cell with a lot of green signal. This is an example of a CD20 positive dominant case. Now we have studied the distribution of these tumor microenvironment immune cells according to the different pathologic features. We examined it against the type, the grade, and the size of the tumor. According to the type, and what is to be expected, that T regulatory cells and tumor-associated macrophages were much higher in the unfavorable triple-negative breast cancer with a significant p-values. And we have found that the luminal cancer had lower values of cytotoxic and CD20 B cells. Further, for the grade, as well, the Treg cells and the tumor-associated macrophages were more dominant in grade 3 cancers. And actually, as well, the T helper cells were more, in our study, were more in the grade 3 cancers, but they have been associated with better overall survival. And this is for the tumor size. Tumor-associated macrophages are much higher in T3, and the cytotoxic the B cells were more in T1. And then correlation with different clinical pathologic features, namely size, lymph nodes, MPI, and the most importantly, the overall survival. And the green one presenting that this is a good prognostic factor, and the red ones are a worse prognosis. And we have found as well that the Treg and the tumor-associated macrophages are significantly inversely correlated with overall survival. And other ones are more with good prognosis, the other types of cells, whether the CD4 positive, the T helper cells, and the CD20. Tumor-associated macrophages were associated with worse prognostic and predictive parameters. As well, FOXP3 positive, the Treg cells were associated with worse prognostic and predictive parameters as well as shorter overall survival. And the tumor-associated macrophages actually increased infiltration by, it's not both, CD4, CD20, and CD8 cells were associated with better disease-free survival and overall survival. To conclude, detailed quantitative tumor microenvironment immune cells percentage and density correlated significantly with patients' clinical data, tumor histopathologic characteristics, as well as overall survival. Hormone receptor negative cancers and grade 3 cancer had higher number of immune cells than luminal and grade 2 cancers respectively. And actually, earlier this day, we were discussing the effect of tumor-stroma ratio with the prognosis of the patients, and our study and many studies before have concluded that tumors with high TSR, high tumor-stroma ratio, which means stroma poor, were significantly correlated with better overall survival. And those with low TSR, meaning stroma rich, were correlated with worse or shorter overall survival. Tumor microenvironment immune cell mapping in breast carcinoma appears to be correlate with the molecular subtype, or appears to be specific to the molecular subtype. What we can recommend is that mapping of TME immune phenotype landscape could therefore provide useful prognostic information. Routine assessment of TILs, which has been established in many centers, and there is the TILs working group, and there is a website which is called TILs in breast cancer. You can find there how to learn how to score the TILs assessment. More research and larger studies are needed to help further elucidate the role of TME in breast cancer and to understand the mechanism underneath the crosstalk between the immune cells. At the end, I'd like to thank the team that I have been honored to work with, Kelly, sorry. Yeah. Ashling, Kelly, Kaisheng, Dan, John, and definitely Dr. Abir. And I'd like to thank you so much.
Thank you, Dr. Mohammed. It's very nice and very interesting and very updated. Thanks a lot. Any questions?
Thank you. أنا سامع حضرتك.
I just wanted to ask what's the difference between this multiplex
Immunofluorescence.
immunofluorescence and the old tissue microarray that we used to do. It's just that you do immunofluorescence afterwards and it's the same technique, wala?
No, the tissue microarray is the construction of this new block, the new paraffin block that I can embed up to 144 cases in just one block.
Oh, so it's
This
the
is-
same, and that's the process of preparing the block,
Yes,
and then
this
you
is
do
the-
the immuno.
Yes, this
So you-
is when we take a section and then we stand it using the multiplex immunofluorescence, which is a very expensive method. And
Yeah, that was going to
needs-
be my second question.
Yeah, but what we can do if we have the tissue microarrayer, which is quite cheaper and available, I think we have a treasury of cases, and I think we can further either stain them using routine immuno, or like updated and new ones, or we can collaborate with other centers outside Egypt. We can do a lot with just the tissue microarrayer, and you have seen it's a very simple and very effective instrument, and
Yes.
yeah, it will be very useful, really.
Yeah, thank you
But
very
the
much.
multiplex as well is very expensive.
Oh, okay.
How many blocks or cores from each case you use?
We have taken
only?
2 from the periphery and 2 from the center to cover like the heterogeneity of the tumor.
And you use blocks of specimen, not
Yes.
core biopsy.
No, not core biopsy.
Okay.
And first we have extracted these excision blocks. We examined them histologically to define if there is tumor and to define where are the cores that I will take out. So I mark this on the slide, then on the block itself.
Okay. And you did this manual because I know there is an automated
No,
machine to
this
do.
was all manual.
Okay. There is automated one to do this.
It would be very expensive, but
yes,
this believe me
I
is,
know. So this is simple and very
yes,
easy.
and it gives it
Yeah.
the same results.
Practical and less cost. And
At the end, you need one slide with all these cases. This would be great.
Questions? So, can I have one?
Sure.
Okay, thank you very much. That was very illustrative. You kept talking on prognostic indices, but I think we have to start talking about predictive indices now. So the relation to immunotherapy, which is the basic and actual practical application for your technique, is to guide the oncologist for further immunotherapy, which is the sort of recent, not really recent, but a new.
It's the PDL1, which is.
نعم.
For example, the PDL1.
Yes, طبعا the PDL1. So I have to start correlating these findings with the predictive markers and the new therapy of PDL1.
Actually, we have these tissue microarray slides, and we have stained them using the PDL1, and we are still working.
Yeah, that would be very interesting.
Yeah.
We would like to know that because people are now
Inshallah.
very much into immunotherapy.
Yeah.
We still do not sort of trust 100% the immunotherapy, as it showed a lot of failures, but this could
Okay.
be a very good and strong sort of delineating the way on how to use the immunotherapy. So you think you'll help in that? Because
We have already them, but we are still working on the analysis. and
PDL1,
score. Yeah,
right?
PDL1.
Thank you.
It's my honor to introduce the next speakers. Thank you, Muhammad. Thank you so much. The next speakers. Next speakers, Dr. Safi Hosni and Dr. Yasmin Jamil. Dr. Safi, she is a lecturer of pathology in NCI Cairo University and a consultant at Bahia Hospital. And Dr. Yasmin Jamil, she is a consultant of radiodiagnosis at Bahia Hospital. They'll talk about Phyllodes tumor from a radiopathology perspective.
Okay. Phyllodes tumors belong to the family of fibroepithelial tumors. They account for 1% of all primary breast neoplasms and 2.5% of all fibroepithelial lesions. The mean age is 40, and they usually present as unilateral firm painless masses. Being multiple or bilateral are unusual. The average tumor size is 4 to 5 centimeter. They may reach more than 10 centimeter with breast distortion and skin ulceration, but skin ulceration alone does not mean malignancy, as it is usually a process of skin ischemia and secondary erosions rather than a malignant process. Lymph node metastases are uncommon, but presence of enlarged reactive lymph nodes can be seen usually due to secondary infection or due to tumor necrosis.
The clinical examination, they both mimic each other. Fibroadenoma and Phyllodes tumor, they are both well-defined, lobulated, mobile, rubbery inconsistency, and painless masses. However, Phyllodes tumor, the characteristic thing about Phyllodes tumor that they show rapid growth. The radiological features are also kind of inseparable. On mammography, they are both large, round, or oval masses with well-circumscribed margins. On ultrasound, they are only distinguished. Okay, the pointer is not working. By internal septations and the Phyllodes tumor show intramural cysts, clefts, and increased vascularity. On MRI, they both show higher signal intensities on T1 images and lower or equal signal intensity to the breast parenchyma on T2 weighted images. As shown here, the above photos are for the fibroadenoma, while the lower ones are for the Phyllodes tumor. They are both similar to each other in their radiological features.
This is a very important table in the WHO book showing the whole spectrum from fibroadenoma to malignant Phyllodes tumor with the 6 main histological features upon which we diagnose cases: the tumor border, the stromal cellularity, the stromal atypia, mitotic activity, stromal overgrowth, and malignant heterologous elements. And as mentioned below the table, that although these features are often observed in combination, they may not always be present simultaneously. So it is a kind of qualitative diagnosis. You sum up all of these features together to get the best diagnosis. And presence of malignant heterologous elements alone can qualify the case as being malignant Phyllodes tumor, apart from liposarcoma, which we will show later. Okay, grossly, they are usually circumscribed masses. Cut section is lobulated, rubbery, cystic, mucoid, and hemorrhagic changes are usually seen. And this is one of our cases for Phyllodes tumor. It seems to be small, but it proved to be a borderline case.
Our first case is a female, 31 years old. She only presented with the right upper outer quadrant large at 2 adjacent palpable masses. On mammography, as shown, they were both intimately related, adjacent to each other, and of intermediate density. On ultrasound, they were large, well-circumscribed hypoechoic lesions. showing tiny cysts within within and clefts, and they were categorized as by RADS 4A.
Grossly, the mass was single, large, circumscribed, capsulated, measuring 14.5 by 11 centimeter. And microscopically, we can see the well-defined pushing border of the mass, the moderate cellularity, and there was no any stromal overgrowth. Stromal overgrowth is defined as a complete absence of any epithelial element within at least one low power field. We can also see the classic large epithelial clefts characteristic of phyllodes tumors. Higher power shows at the left side the bland-looking double-layered epithelial component and the stromal mild atypia with inactive mitosis. This case also showed low mitotic rate. It was just 1 per 10 high power field, and there were no any associated malignant heterologous elements. So what is the diagnosis? It is a straightforward case of benign phyllodes tumor. Our next case is a rather complex case. It is a young lady, 27 years old. She first presented to Bahia in 2018 by 3 right-sided masses. Then 1 year later, she presented with other 2 ipsilateral masses. 9 months later, other 8 ipsilateral masses. All these masses was treated by excision, lumpectomy, and they proved all to be ranging from cellular and complex fibroadenomas. Then 6 months later, which means in 2021, she presented with 40 masses, ipsilateral in the right side, ranging in size from 10 by 8 centimeter to 1 by 1 centimeter, and this is what we will show now.
One of the masses, as Dr. Safi told us, was located in the right breast, 10 o'clock. It was well circumscribed as seen, isoechoic, oval shaped, measuring about 4.7 times 2.2 centimeter. It was categorized as by RADS 3.
And this is the histological picture. The low power shows complete absence of any stromal overgrowth with mild cellularity. Higher power show mild atypia, inactive mitosis, and the characteristic subepithelial accentuation known for phyllodes cases. So this case was diagnosed as multiple benign phyllodes tumors, and other tumors showed fibroadenoma, cellular fibroadenoma. So it was diagnosed as multiple benign phyllodes tumor and multiple cellular fibroadenomas.
On April 2020, she underwent simple mastectomy for a recurrent huge mass. This is a photo immediately before her surgical intervention was done. These masses were seen on ultrasound before her surgery as multiple intimately related variable-sized heterogeneous hypoechoic solid masses showing internal cystic changes. The largest is seen at right upper outer quadrant, measuring about 5.6 times 3.1 centimeter. They were categorized as by RADS 4A.
Grossly, it proved to be a single huge nodular lobulated mass, 20 by 17 by 12 centimeter, and microscopically the borders were pushing. Mitoses were about 5 per 10 high power field. There was associated infarctive necrosis. There was wide areas showing stromal overgrowth with moderate cellularity. Also stromal edema can be seen in this photo. The right-sided insert shows associated moderate atypia. Higher power view showing the mitosis. And interestingly, this case at the peripheral sections taken from the mass showed classic pericanalicular fibroadenoma. So this case was diagnosed as a recurrent borderline phyllodes tumor.
Interestingly, the same patient presented in May 2022 with contralateral on the left side, lower outer quadrant palpable lesion. On ultrasound, it was a left breast 4 o'clock oval-shaped mass of mixed echogenicity showing central vascular twigs as seen in the slides. It was categorized by RAS3.
When the mass was excised, it showed cellular stroma, but with evenly distributed epithelium showing usual ductal hyperplasia with no active mitosis, no atypia. So we diagnosed the case as being a contralateral cellular fibroadenoma. So it is uncommon to see cases that move or transform from being fibroadenoma to malignant phyllodes tumor, but that is reported. And this was a similar situation in our case, which transformed from being fibroadenoma, cellular fibroadenoma, to borderline phyllodes tumor.
Our third case is a 46-year-old female presented with right-sided 12 o'clock mass. On mammography, it was an upper central ill-defined mass of mixed density harboring microcalcification, measuring about 4.4 times 4.6, and the AI, the artificial intelligence, gave her about 96% suspicion. Ultrasound showed right 12 o'clock suspicious complex cystic mass. There were no associated ipsilateral pathological axillary lymph nodes. It was categorized as by RADS4B.
The patient underwent wide local excision. It was a rather small, solid partially cystic mass, 3.5 by 2.5 centimeter, and the least surgical clearance was 0.5 centimeter regarding the upper, lower, and lateral edges. And this is the histological pictures. We can see here there is marked infiltrative border where we can see a tumor area completely within the surrounding fat, and the high power view show the marked atypia and the associated active mitosis. There was also marked cellularity, wide areas of stromal overgrowth, and mitosis was counted to be 9/10 high power field. So the case was diagnosed to be malignant phyllodes tumor, and the surgeon had to go back to do wider excision to reach a complete 1 centimeter margin all around the tumor. This case also showed areas with prominent, well-differentiated liposarcoma component, and as we said before, if this entity we find it alone in phyllodes tumor, we cannot qualify the case as being malignant. We should find other features such as the mitosis and the stromal growth and infiltrative borders to say that it is malignant.
The main take-home messages are that imaging alone is not adequate to differentiate between fibroadenoma and phyllodes tumor. However, the presence of single or multiple round cleft-like cystic spaces, as were shown in our presentation, and high vascularity in the solid components strongly suggest the diagnosis of phyllodes tumor. They are frequently classified as by RADS4. In practice, most lesions are indistinguishable from fibroadenoma on both mammography and ultrasound. This is why interval enlargement of fibroadenoma is seen as an indication for core biopsy. Large lesions more than 4 cm may qualify for excision, as core or needle biopsy may not be representative for the whole lesion.
And according to the guidelines of the Royal College for diagnosing breast biopsies, phyllodes tumor is under the category of B3, which includes all benign histology on core biopsy that carries either heterogeneity or increased risk of associated malignancy. So in these situations, atypia should be reported adequately, whether it is present or absent. So when we receive a biopsy and it just shows a cellular stroma within a fibroepithelial lesion, we can diagnose it as cellular fibroepithelial neoplasm, and we can recommend complete excision of the mass with an intact capsule. We can say that possibilities include benign phyllodes tumor and cellular fibroadenoma. But if we were lucky enough to find other features such as the stromal overgrowth or tumor fragmentation, multiple mitoses, 3 or more, or marked atypia, then we can confidently diagnose the case as phyllodes tumor, at least borderline, and we recommend the surgeon to take a wide excision, at least 1 centimeter, to decrease the incidence of or the risk of subsequent recurrence for both borderline and malignant phyllodes tumors. Thank you very much.
Thank you, Dr. Safi and Dr. Yasmin. Any questions?
عايزه اسمع راي دكتوره ناديه ودكتوره عبير في الموضوع ده، لان انا كتير جدا بيجي لنا عيانين اللي هي تقول لي انا عندي فايبرو ادينوما وفجاه لقيتها بتكبر، فهي اوريدي كانت موجوده كذا سنه. يعني ما كانتش باينه ان هي يعني ما كانتش في اللويدس من الاول، هي كانت فايبرو ادينوما فعلا ستيشنري وفجاه بتكبر، لما تتشال نكتشف ان هي في اللويدس. هي لو في اللويدس من الاول كانت كبرت، صح ولا غلط يا دكتوره عبير؟ ايه
صحيح. we do see these انها ممكن تبقى تبتدي بفايبر ادينوما وبعدين بعد كده تريكير وتبقى phyllodes. In fact, Rosen says about 15 to 20% of all phyllodes will have a portion of fibroadenoma, indicating that phyllodes has arisen on top of a fibroadenoma. So it happens and it's not uncommon.
ما هو ده اللي كنت عايزه اقوله لصافي، ان هي مش يعني انا بالنسبه لي كشايفاها كلينيكال سيناريو اتس نوت انكومن. يعني اذا كان احنا في بهيه كتير عندنا جدا فايبرو ادينوماز اللي قلبوا كارسينوما، ودي كانت حاجه الواحد فاكرها انها حاجه ريموت قوي يعني لكن واقع ان هي بنشوفهم. الحاجه الثانيه على الارتفيشال انتليجنس، انا دي برضو حاجه انا مش قادره افهمها، هي كايمجينج فيتشرز ان انا اقول دي بناين ولا بوردر لاين ولا مالجنت، الثلاثه بالنسبه لنا واحد كايمجينج، unless ان هي يكون معاها اكسيلري ليمف نودز او ميتاستاتيك، وعندنا كذا حاله فعلا ميتاستاتيك لانج من فيلويدز. فالغريبه ان احنا لما بنابلاي الارتفيشال انتليجنس اصلا ما بيشوفش الفيلويد، بيقراها على انها بناين او بيديها سكور واطي. فانا مستغربه قوي ان هي المالجننت اللي هو ما فيهاش فيتشرز اصلا ايمجينج وايز،
كانت تقريبا الاكسبشن للقاعده يا دكتور رشا.
ايوه يعني انا بقول لك السنه دي لسه يعني شايفاها في التيومر بوركوت، فاستغربت اشمعنى دي. طب انت ايه اللي شفته، ايه اللي شافوا الارتفيشال انتليجنس فيها زياده؟
even for the pathologist it's a
بيقرا
very
الغيب. نعم، ما هو مش كومن كمان انها يبقى فيها كالسيفيكيشن الفيلويدز، مش كومن الكالسيفيكيشن في
هي الفكره حكايه ان هي بتبقى يعني كذا حاجه بنحطها مع بعض عشان نشخصها فعلا. فهي ممكن لو حاله الميتوزس فيها مش عالي قوي بس ليها اسباب تانية خلتنا نقول عليها مالجننت، ممكن الارتفيشال انتليجنس ما يقراهاش مثلا. انما لو هي فيها ميتوزس عالي قوي وكده واتيبيا عنيفه،
بس طب هيشوفها ازاي دي يا صافي؟ هي يمكن فعلا لو كان فيها كالسيفيكيشن هو دي يعني اللي ممكن تخليه يقراها يعني.
احنا بنقعد كتير عبال ما نشخصها، احنا عايزين سكشنز كتيره وبنبقى كتير ما بين بوردر لاين ومالجننت وبيناين وبوردر لاين يعني بنبقى عايزين نقطع من العينه كتير سكشنز كتيره جدا عشان نوصل للتشخيص المظبوط يعني.
بس هو انا ليه اعتراض بس على حاجه كمان من ياسمين، هو ايمجينج وايز احنا اللي اشتغل وشاف فيلوديس تيومر كتير هيقدر يقول دي فايبرو ادينوما ولا لا، او اتليست هيبقى عنده هاي سسبشن ليها، لان السليت لايك سبيسز اللي هي انتوا بتشوفوها كليفتس او كده دي بتبقى واضحه، ما بنشوفهاش قوي في الفايبرو ادينوما. والانكريست فاسكولاريتي دي مش كومن مع انا وانس ان انا شفت التو ساينز دول لازم هديها بايرات سبور، مش هعملها على انها فايبرو ادينوما بس.
لا انا ما كانش ده المقصود من المسج، بالعكس انا كان قصدي امفاسايز الحاجات اللي حضرتك قلتيها.
ايوه
طيب ان دول لو موجودين يبقى ده في
يبقى هي بس بس ما شاء الله حلوه قوي.
طب ممكن اعلق بس تعليق صغير دكتوره رشا. فيلويدس وبريست كانسر these are two different diseases. هنا بنسميهم collision tumors لكن عمرها ما بتبقى progression. But from the fibroadenoma to phyllodes there are pathways for genetic progression دي مختلفه تمام.
هي دكتوره رشا تقصد يا دكتوره ناديه الدي سي اي اس اللي ساعات بنشوفه جوه الفايبرو ادينومز.
Again this is a different disease altogether molecularly مختلف تماما، الباثوي مختلف تماما، وبنسميهم كوليجن زي اللي بيحصل في البلادر والبروستات وهكذا. كوليجن تيومرز، ناس اتنين خبطوا في بعض ما لهمش علاقه ببعض وخبطوا في بعض، it happens. But from fibroadenoma to phyllodes it's a progressive genetic alteration. بس
هو الفكرة برضو يا دكتورة رشا ان احنا يعني we should be cautious جدا في الدياجنوزس بتاع الفيرلايدز، يعني يبقى عندنا high level of suspicion للحالات اللي بالشكل ده، عشان يعني من يعني الحاجات اللي هي البيناين لوكينج ليجنز ما نقولش عليها فايبرو ادينوما وخلاص. يعني اعتقد ان هي
يعني فعلا حتى لو في صغيرين او كده بنديهم فيروس، تيجي بقى في الفولو اب نشوفها كبرت او ما كبرتش او كده، بقى هي دي او المورفولوجي بتاعها اتغير او كده. لان احنا يعني شفنا اللي ما شفناهوش عمرنا في بهية الصراحه.
لا انا اقصد يعني البيناين لوكينج ليجنز اللي هي اللوبيوليتد اللي فيها السيستيك تشينجز اللي فيها الهاي فاسكولاريتي زي ما حضرتك يعني في الحاجات اللي هي سسبيشس للفولويد، السايز بتاع التيومر. كل ما احنا برضو نشوف اي حاجه سسبيشس في الحاجات دي، يعني I think we should consider يعني بايوبسي اتس بيتر، يعني تو بي سيف احسن ما نقول ان دي فايبرو ادينوما ونديها فيروس 3 يعني I think ان دي المسج اللي انا يعني فاهمها حتى من الحالات اللي اتعرضت دلوقتي، يعني حالات ممكن تبقى يعني باينه في الايمجنج ان هي فايبرو ادينوما وفي النهايه بتطلع فيرلويد تيومر يعني.
ممكن اعلق بس؟
اتفضل.
هي الحاله الوحيده اللي كانت عندنا في الكيسز واخده فيروس 3 كانت هي اللي تيبيكالي شكلها فايبرو ادينوما، بس احنا اديناها برضو فيروس 3 for the sake of the patient ان هي تيجي for follow up. اي حاله بنشك فيها high vascularity او الكلافts او السيستيك changes دي بنكاتيجورايز على طول على فيروس 4 عشان for histopathological assessment. ميرسي لحضرتك.
Thank you so much. Thank you. The next talk will be by دكتورة إيناس سويد. دكتورة مهتاب تهامي. دكتورة إيناس is lecturer of radiology in Banha University. The title would be primary breast lymphoma.
Thank you for the introduction. While lymphomas are the most frequent hematologic malignancy, association with breast is rare, especially primary breast lymphomas. Breast lymphoma may occur as an extranodal primary disease or as a result of secondary systemic dissemination. Primary breast lymphoma is a rare entity that accounts for only 1% of malignant breast neoplasm. The most common clinical presentation of primary breast lymphoma is a palpable painless mass in the upper outer quadrant. Other manifestations are pain, local inflammatory signs, and palpable adenopathies. Asymptomatic incidental finding can occur on mammography in 12% of cases, and the regional lymph nodes are involved in 50% of cases. Bilateral disease is described in about 11% of cases, but the usual symptoms of lymphomas are very rare in primary breast lymphomas. The mean age of diagnosis is 60 years with right side predominance. The criteria of primary breast lymphoma were first described by Wiseman and Leo at 1972, and this definition remains unchanged till today. The criteria were the breast is the site of presentation, and the breast tissue is in close relation with the lymphomatous infiltration, the absence of disseminated disease beyond the ipsilateral axillary nodes, and the absence of a previous lymphoma diagnosis. The most common histological type of primary breast lymphoma is the diffuse large B-cell lymphoma, marginal zone lymphoma, mild lymphoma, and follicular lymphoma, Burkitt lymphoma, and the rare type anaplastic large cell lymphoma.
Radiological features of primary breast lymphomas. There is no single imaging finding. There is no single imaging finding diagnostic of lymphoma. A biopsy is typically required for diagnosis. Enlarged intramammary lymph node may be seen, but also can be seen in other breast malignancy. Mammographic finding. The most common site of primary breast lymphoma in the breast is upper outer quadrant in 40%, upper inner quadrant in 20%, and the less common site is lower outer quadrant and the nipple and areola complex. With right side predominance for primary breast lymphomas. There is 3 common mammographic findings for primary breast lymphomas. The most common is solitary non-calcified breast mass with circumscribed or indistinct margin, not accompanied by speculation, not accompanied by artificial distortion, no nipple or skin retraction or nipple discharge. This is the most common presentation in mammogram. Secondly, it can be presented by global asymmetry in 1/3 of the cases and is associated with high-grade lymphomas. Less commonly, it can present by lymphedema. We will apply the 3 presentation of mammogram in our cases 1 minute later. Ultrasound finding. The most common presentation of primary breast lymphomas in ultrasound is hypoechoic solid over round or irregular mass with circumscribed or indistinct margin. Orientation is usually parallel. Less commonly, it can be presented with hyperechogenic or pseudocystic appearance. Posterior acoustic enhancement is present in 52 to 75% of masses. Hypervascularity is detected in 55 to 64% of masses. MR finding. Primary breast lymphomas usually present with T1 iso-intense, T2 hyperintense, T1 post-contrast usually present with marked inhomogeneous contrast enhancement with type 2 kinematic curve is the most common, and actually it usually take fast early enhancement. Diffusion weighted image because of cell density, it usually of restricted diffusion. PET scan is very important in patients with primary breast lymphomas. It is very important in staging and follow-up and evaluating response to treatment. Usually the primary breast lymphomas show avid homogeneous FDG uptake with mean maximum SUV of 10.6. Less commonly, it may present with ring-like uptake. And this case from the literature show pathological proved case of diffuse large B-cell lymphoma show avid homogeneous FDG uptake with pathological axillary with pathologically enlarged with pathological enlarged lymph node, and after 3 cycles of chemotherapy, it show partial response. Differential diagnosis of primary breast lymphomas include primary epithelial breast cancer, fibroadenoma, phyllodes tumor, and metastasis to the breast.
Herein we present 4 of our interesting cases at Bahia, diagnosed at Bahia this year. The first case was a 60-year-old patient who underwent left-modified radical mastectomy for invasive duct carcinoma grade 2 in April 2021 at Bahia Center. The patient had been receiving her adjuvant systemic treatment. Then a right breast mass was filled during her follow-up period on July 2022.
The diagnostic CC and the MLO of right breast show right upper outer quadrant, irregular, speculated margin, high density mass. On ultrasound, it show right breast 11 o'clock, irregular shape, speculated margin, hypoechoic mass with pathological enlarged axillary lymph node. True cut biopsy was given.
Microscopic examination revealed vaguely nodular and diffuse growth pattern of medium-sized lymphocytes with slightly irregular nuclei and low mitotic rate. Immunohistochemistry was done and revealed negative reaction for cytokeratin, which highlighted the residual ducts, as seen here. CD20 diffusely stained the tumor cells. CD3 stained the reactive background T lymphocytes. And Ki-67 was low, so the diagnosis was multiple lymphoma with recommendation of excision. Excision was done and the mass was 3 by 3 centimeters in size, fairly defined and of white and firm cut-section. Microscopic examination revealed sheets of intermediate sized lymphocytes with areas of larger lymphoid cells and showing ample cytoplasm and vesicular nuclei with scattered apoptotic bodies. Markers done revealed absent reaction of the tumor cells for cytokeratin and diffuse positive reaction for CD20. CD3 stained the reactive T lymphocytes, but Ki-67 was high on the excision specimen. So the diagnosis was reported as diffuse large B-cell non-Hodgkin lymphoma progressed from multiple lymphoma. The second case was 51 years old female patient presented by a right breast mass of 1 month duration, which was soft on palpation.
Diagnostic CC and MLO of both breast show right upper outer quadrant and central global asymmetry, no associated calcifications. On ultrasound, it shows right 11 o'clock infiltrative, irregular shape, speculated margin, heterogeneous hypoechoic, hypervascular mass, no associated axillary pathological lymph node. And was BIRAT 5 was given and true cut biopsy was taken.
Microscopic examination revealed sheets of large lymphoid cells, and cytokeratin was totally negative in tumor cells. CD20 is diffusely positive. CD3 stained the reactive background T lymphocytes, and Ki-67 was high. Diagnosis was reported as diffuse large B-cell non-Hodgkin lymphoma. The third case was a 26 years old female patient complaining of left breast mass of 6 months duration.
Diagnostic CC and MLO of both breast show bilateral diffuse breast edema manifested by increased skin thickening, increased parenchymal density, and coarsened trabeculae. Ultrasound was done, which show confirms the breast edema in the form of skin thickening, interstitial edema pattern, and smudged fat lobule, pathological enlarged right axillary lymph node level 1 and level 2, pathological left axillary lymph node, and the ultrasound demonstrate left breast 7 o'clock zone C, irregular, indistinct margin, hypoechoic, with no vascularity detected, with on Doppler mapping. True cut biopsy was taken from the right pathological axillary lymph node and the left breast mass and was categorized as BIRAT 4.
Both biopsies showed the same picture of a polymorphic infiltrate of scattered large mono, binucleated and multinucleated cells having a prominent eosinophilic nucleoli and admixed with an inflammatory background. Markers done revealed positive reaction of the large cells for CD30 and CD15. MUM1 also showed positive nuclear reaction in tumor cells. EMA was negative. CD20 was negative, but CD3 stained the reactive background T lymphocytes. The diagnosis was classic Hodgkin lymphoma mixed cellularity. The fourth case was a 60 years old female patient presented by bilateral breast masses.
Diagnostic CC and MLO of both breast show left breast lower inner quadrant circumscribed over-shaped hyperdense mass with indeterminate axillary lymph node, and there is actually 3 similar but smaller masses can be demonstrated here as the axillary tail. Ultrasound was done and revealed there is the left breast mass, the left breast 9 o'clock microlobulated over-shaped hypoechoic vascular mass with indeterminate axillary lymphadenopathy level 1. And on the 3 axillary tail masses was demonstrated on the mammogram appear on the ultrasound. One of them was solid overshape and hypoechoic. The 2 masses was heterogeneous hyperechoic and hypervascularity, and was BIRAT 4 was given. And true cut biopsy MRI was done. And the breast masses were taken the same MRI features of low signal intensity in the T1, hyperintensity in the T2, pathological node, diffusion restriction of bright diffusion weighted images and low ADC, and inhomogeneous post-contrast enhancements and type 3 curve with rapid washout. True cut biopsy are taken from the two breast masses, bilateral breast masses.
Both biopsies showed the same picture of sheets of intermediate-sized lymphoid cells with vaguely nodular growth pattern. A higher view. Immunostaining revealed diffuse positive reaction for CD20. CD3 stained the background T lymphocytes, and Ki67 was about 15%. Diagnosis was bilateral breast multilymphoma. Management according to the NCCN guidelines, as for low-grade lymphomas, excision and plus or minus radiotherapy is almost curative. If cases were symptomatic, rituximab may be added, but recurrence of the disease indicates rebiopsy to exclude progression to an aggressive disease. For high-grade lymphomas, systemic treatment by 4 cycles of R-CHOP regimen is described. And for Hodgkin lymphoma, chemotherapy ABVD regimen is the standard line of treatment. So as we can see, the primary treatment doesn't involve surgery in some cases, but a combination of chemotherapy and radiation. And in view of the similarities between carcinomas and lymphomas on clinical and radiological basis, immunohistochemistry and histological examination remain the gold standard in diagnosis of lymphoma.
Although it is difficult to make the diagnosis of malignant lymphoma based on imaging finding alone, should be considered in differential diagnosis of any mass lacking speculation, architecture distortion of microcalcification, skin or nipple retraction or nipple discharge, we must put primary breast lymphoma or lymphomas in your differential diagnosis to convey the pathologist that it is in one of your differential. Also, it is very important to briefly to conclude that clinically, most of the lymphomas can be feel softer than the breast cancer on palpation, and radiologically, a mass lacking speculation, architecture distortion, or calcification should be right in your report that it is a suspicious mass lymphoma is one of my differential diagnosis, because the management from breast cancer differs, but still,
pathology remains the gold standard.
And after the pathology is established, a PET scan must be done to confirm the diagnosis that it is a primary breast lymphoma, and to exclude that there is no any other lesions, to confirm in the primary, not a secondary lymphoma. Thank you so much.
شكرا جزيلا دكتورة إيناس، شكرا جزيلا دكتورة مهيتاب. ولو إن إيناس ما قالتش كملت الجملة بتاعتها، الباثولوجي هو الجولد ستاندرد. شكرا جزيلا ليكم. Any question?
Thank you both very much.
Thank you.
Mahtab, you mentioned the first case. افتكري معايا first case. The biopsy was malt and the specimen was diffuse large. Yes. What's the time lapse between them?
2 months.
You cannot call this progression. No. This is one of the same disease. احنا لو رجعنا الأيزاكسون classification بتاعت المالت في الستومك, you will say that grade 1 up to 4, and in between grade 3 and 4 they do have a mix of small malt element and a large component. So I would rather not call this progression. I would call this an intermediate phase of malt with large cell component, or it's according to the percentage that you see.
It wasn't sampled in the first setting.
لا أنا بس اعتراضي بس على مش اعتراضي يعني قصدي my comment is not to call this progression if it is 1 or 2 months duration. It's one and the same disease. Thank you.
Thank you.
Questions يا جماعة؟ نمتوا؟ حالات very interesting and you don't see it frequently. فيعني أكيد في حاجة مستغربين لها. Hodgkin's مثلا. Do you think it's an extranodal disease or a nodal disease? There was an associated lymph node, صح?
Yes.
There was. So it is rather a nodal disease with parenchymatous dissemination.
هو actually احنا to diagnose primary breast lymphomas يعني هي زي ما دكتور مهيتاب mention we must يعني restrict to the criteria ان احنا عندنا ان breast tissue lymphomatous infiltration in the pathological specimen, no disseminated disease at time of diagnosis, no extra memory lymphoma at previous. يعني العيانه ما تجيش تقول ان جالها مثلا ميديستانال ليمفوما من سنتين ثلاثه، ما تبقاش عندها disseminated disease at time of diagnosis عشان شخص ان هي primary. to diagnose ان هي primary breast lymphomas هي دي الكرايتيريا اللي established actually في 1972. يعني عشان كده احنا حتى بنقول بعد الباثولوجي لازم العيانه تعمل بيت سكان، لو عملت بيت سكان ومفيش اذر ليمف نود الا بس في الابسيلاترال سايد بندايجنوز برايمري بريست ليمفوماز.
طب انا عايزه اسال مهتاب، did you consider this an extra nodal with nodal or nodal with extra nodal or how do you put it, because the management is totally different. You have to tell the oncologist how to proceed. I think this has to go with nodal dissemination, nodal disease with dissemination into parenchymatous, صح?
I think so.
Because we have lymph node.
Okay.
Then extranodal Hodgkin is not known to cause lymph node metastasis and vice versa. Vice versa is applicable. يعني لما يكون في lymph node it can invade the parenchyma. But the parenchymatous lymphomas do not usually disseminate into the nodal compartment عشان الهومينج theory. عارفة طبعا الهومينج theory بس.
Thank you.
I want to ask Dr. Nadia a question. If in a core biopsy, yeah, this is for you. If in core biopsy I diagnose this malt lymphoma, and we know the difference between the treatment malt and diffuse large, but the case contains area of diffuse large which is I don't know. So shall I ask for another biopsy to make sure that this is malt or excision, and I will see this?
They don't like the term re-biopsy دي، ما بيحبوهاش مننا جدا، يعني بيعتبرونا ضعفاء نقص بتاع. I would put it as a mix of كذا a grade in between that could be upgraded or down. لا not downgraded but could be upgraded. Could be upgraded لأنك متشاف you don't see the. Yes, ده بعد التريتمنت not before treatment. Yes, you can recommend that, but please always mention the percent of large cells. It's very very important. حتى I keep repeating Isaacson في الstomach بيقول كده please put a number for the large cell because it is the prognostic component.
Any questions? Okay, thank you. Thank you. Okay, our next section will be fibroepithelial tumors with carcinoma and will be presented by Dr. Maha Ghnemi, Professor of Maha Ghnemi, Professor of Pathology, Consultant of Pathology at Bahia Center, and Dr. Amira Karam, Consultant of Radiodiagnosis at Bahia.
Good evening. I hope you guys are not sleeping. Our presentation is going to be very, very simple. It's about fibroadenoma. I know everyone knows about fibroadenoma, but we're talking about in situ an invasive disease inside the fibroadenoma. So we're going to present quickly, very, very quickly about what is a fibroadenoma and the different types, and we're going to present only two interesting cases that we have encountered in the last few months in Bahia. Fibroadenoma is the most common benign tumor in females. It can also occur in males with gynecomastia. It is common in adolescents and young women, rare before menarche, and the complex fibroadenoma occurs at a higher age group, 2 decades later than that. It is usually a sporadic disease. However, the myxoid fibroadenomas can occur in Carney's triad. The growth is hormonally dependent, وبالتالي it grows very much during pregnancy. On gross examination, it's a well-circumscribed tumor, lobulated, has a grayish-white cut section, and you can also see the slit-like spaces on the cut section. We have two types, the fibroadenoma that we call just fibroadenoma, which is the conventional fibroadenoma, and the complex fibroadenoma. The size is usually around 3 centimeters. When it's more than 5 centimeters, we call it giant fibroadenoma, and this is the one that is more common in adolescent girls. The one that we call just fibroadenoma is either intracanalicular, where the stroma grows and compresses the ducts and you see the slit-like spaces. And the pericanalicular is the one where the stroma grows around the patent ducts. And we usually have a mixture, well, not usually, but we always tend to see a mixture of both intra and pericanalicular. There is no prognostic significance. We just need to just mention the type. The relative risk of developing a subsequent breast cancer in a normal fibroadenoma is 1.5 to 2 in those females. Radiologically,
the simple fibroadenoma, which is commonly seen, is characterized by being oval or rounded shape with circumscribed margins, as you can see this lesion in mammography. It has parallel orientation. That means that the lesion is parallel to the skin, or in another word, it is wider than taller. It is homogeneously hypoechoic in ultrasound. It may show internal septations that appears echogenic in ultrasound and dark non-enhancing in MRI.
The other type, which is the complex fibroadenoma, we call it complex when we see certain criteria on histology. One is the sclerosing adenosis, this area of crowded glands together, the sclerosing adenosis. And if we see papillary apocrine metaplasia, or we see cysts that are larger than 3 millimeter in diameter, or we see epithelial calcification. The risk of a subsequent breast cancer in a case of complex fibroadenoma is definitely higher than the risk in a conventional fibroadenoma. It reaches 3.1 compared to 1.5 to 2 in the normal or the simple fibroadenoma.
The complex fibroadenoma is different from the simple by having some atypical criteria as irregular outlines. As we can see in this image, it may increase in size in follow-up studies, but this increase should be significant, more than 20%. It may show increased vascularity on applying color Doppler. It may show cystic lakes appearing as anechoic regions within the fibroadenoma. It may show internal microcalcifications appearing as echogenic dots on ultrasound. It is easily detected, these microcalcifications, on mammography.
Well, as we all know, fibroadenoma is a biphasic tumor. We have stroma and we have epithelium, and we can see changes in the stroma as well as changes in the epithelium. Common changes that we see in the stroma is the fibroadenoma becoming very cellular, and we call it cellular fibroadenoma, provided that we have no atypia and no significant mitotic activity. Accepted is around 1 to 2 per 10 high power fields, nothing more than that. So this is the cellularity. When it is cellular and intracanalicular, it looks very much like a benign phylloides tumor, and we have to look at all the criteria that have been mentioned before to do this differentiation between whether it's a cellular fibroadenoma or a benign phylloides tumor. Another rare stromal change that can happen, and it's a bit scary for a pathologist, and we see it, and we've just encountered one case lately, is when you have those large giant cells in the stroma. In a cellular stroma, when you have those giant cells looking ugly at a high power, but when you go when you go on high power, they're smudgy and they're degenerative, and it is a benign change. It does not make it any malignant. It's a benign change that we can encounter in the stroma. However, it's not very common, so don't get scared when you see it. Again, no atypia, no mitotic activity. Fibroadenomas can harbor epithelial change. The same epithelial changes that can happen in the normal surrounding breast tissue can also happen inside the fibroadenoma. The usual one that we encounter is the usual ductal hyperplasia. We see it a lot in fibroadenomas, and we just diagnose it as fibroadenoma. We can see atypical ductal hyperplasia, like the one we see here. This is the duct. It's just a bit hazy, but it has atypical ductal hyperplasia. I'll show you better pictures later on. You can also see DCIS inside the fibroadenoma, and you can have invasive carcinoma, whether it's invasive lobular or invasive ductal carcinoma. Invasive carcinomas happen in fibroadenomas in two forms. Either they're spreading from the surrounding breast tissue that has an invasive cancer that spreads inside the fibroadenoma, or it occurs inside the fibroadenoma alone and there's nothing outside. The presence of atypical features inside the fibroadenoma does not denote an increased subsequent risk of malignancy. If the atypia is confined to the fibroadenoma, for sure the atypia is confined to the fibroadenoma only, then there's no increased risk here. The risk is still the same. Now we present our cases.
Our first case, 45-year-old female with right breast palpable lump. We started by mammography. Right CC and MLO views, ACRC breast, we can hardly appreciate this upper outer quadrant medium dense lesion with obscured margins. Complementary ultrasound was done, which revealed the right upper outer quadrant sizable hypoechoic lesion with some atypical criteria in the form of lobulated outline. And there was focal angulation, so the lesion was diagnosed as right upper outer quadrant, probably benign lesion, by RET 3 with worrisome criteria, and the histopathology was recommended.
Well, we received the score, and we received multiple core biopsies ranging in length from 1.3 centimeters to 2, and this is how we report we have to say how many cores we receive and the length of the cores we receive, and this is what we see. So what do you see? This is what we had in the cores. Pathologist here. It's just a fibroadenoma. It's a pericanalicular fibroadenoma. They saw a lot of worrisome features on mammography, but what we had on the core biopsy was just a normal fibroadenoma. So we reported it as fibroepithelial tumor consistent with fibroadenoma. However, you see abnormal features, so it's your call, correlate with clinical and radiological data. So it's not what we see is just that, but you see different things, you have to deal accordingly. So case was discussed in MDT, and as we discussed most of the cases in our MDTs, and the decision was taken based on the abnormal radiological findings that were seen. The decision was taken to excise the mass. So an excision was done. The mass was 3 by 3 by 1 centimeter in diameter, encapsulated, looking exactly like a normal breast fibroadenoma. What you see on that field was just the pericanalicular fibroadenoma that we saw on the core. But in other fields, we saw these acini that are filled with epithelial proliferations on a low power. So you go to the high power, you found that these epithelial proliferations are more monotonous and a little bit more atypical than you expect. You go on a higher power and you see this is probably, it looks like a DCIS, an intermediate to a high grade DCIS. So when we suspected that this might be DCIS, we resorted to immunohistochemistry, which we must do. We do not diagnose only DCIS based on the fact that they are just rounded, but we have to do immunohistochemistry to confirm. We did the ER. You see diffuse positive staining of the cells, the epithelial proliferations inside the ducts, the acini. And we did the CK56, which is a myoepithelial marker. Normally, if this is DCIS, it would delineate all the ducts. Now, what we saw here is there are some of the acini, they had these myoepithelial cells around them, but others, most of them did not have the myoepithelial cells. We do not do usually one myoepithelial markers, we do more than one. One very interesting one, which is it has a nuclear, it stains the nuclei, is the P63. So you can see here the P63 delineating the normal ducts here, or the normal acini. So the myoepithelial cells are there, but in most of those masses, we don't see myoepithelial cells. Another marker, the S100, which gave us basically the same results. So we, another thing before I say the diagnosis, and we examined the breast tissue around the fibroadenoma, which is something that we should always do and not forget to do. And there was actually foci of DCIS outside the fibroadenoma in the breast tissue around. They were close to the margin. They were 1 millimeter from the margin. And the margin for DCIS should not be less than 2 millimeter. Margin for the invasive carcinoma is tumor on ink. Margin for the DCIS is 2 millimeter. This one was 1 millimeter. So our report was fibroadenoma involved with an invasive duct carcinoma and an intermediate grade DCIS. This was a PT1NX. We don't have the lymph nodes because this was excised as if it was just a fibroadenoma. We have to report that the DCIS was found at 1 millimeter from the margin because this necessitates further or wider excision. بما ان هي طلعت invasive carcinoma, so we did the ER, PR, and HER2. It was ER positive, PR positive, and HER2 negative. A wider excision was done again because of the margin, and when we received the wider excision, it was a big excision. It was a 14 by 6 centimeter that harbored a nodular area 2 by 1.8. The margins were inked. 8 sentinel lymph nodes were found. On examination, the further excision had only DCIS. There was no invasive component, had only DCIS, intermediate grade with comedo necrosis. All sentinel lymph nodes were examined. They were all negative. So our report was residual DCIS, intermediate grade resections, margins are free, and the sentinel lymph nodes are free. So I guess set PT1 and 0.
Our second case, 35-year-old female with left breast palpable lump. She is under 40, so the ultrasound was the examination of choice. By ultrasound, we found the left upper outer quadrant sizable mass reaching 5 centimeters on the longest diameter. It was a hypoechoic oval-shaped lesion, but with atypical criteria in the form of lobulated outlines, areas of cystic changes, and foci of calcifications. So the diagnosis was left upper outer quadrant, moderately suspicious mass, Barrett's 4A, and Hess pathology was recommended.
Again, we received the cores in the pathology department. 5 cores were received. And what we see on a low power is a fibroadenoma with the asini having an epithelial proliferation that looks from the low power like it's UDH, which is something that we commonly see. But there's this focus from the low power you can see on the side here. Sorry. On the side here that looks a little bit a bit different. So when you go on high power, the cells, the asini had this more monotonous proliferation that looks more like atypia, more atypical cells, different than the cells in the other areas. So the diagnosis came out as a fibroepithelial tumor consistent with a fibroadenoma with extensive UDH and focal ADH. So we find some just a little small area less than 2 millimeter that had the atypical findings. So we said focal ADH, and we recommended complete excision. The excision came, it was an encapsulated mass looking like a normal fibroadenoma, 5x3, white and rubbery cut section. And on histological examination, you can easily say the diagnosis here, it's a complex fibroadenoma. You see the large cyst 3 millimeters, the sclerosing adenosis, it's a complex fibroadenoma. You see the UDH, you see the border is very well circumscribed with the capsule, and you see the UDH on one side. And this area that we were worried about, that had the atypia, had those more monotonous proliferation. They look rounded, they look like a DCIS. So again, because we had this previous case where we thought it was DCIS and it turned out not to be DCIS and invasive. So again, we always need to do the immunos. We did our immunos, and as you can see here, the CK5-6, in some of the ducts, you can look at these ones. You can see CK5-6 around the duct and inside. So these are the UDH. These are the ones that are benign. But the ones that have the staining only in the myoepithelial cells around and there's no staining inside, these are the ones that are atypical, and therefore we call them DCIS. Again, the ER was diffusely positive in those asini, which is a characteristic feature in this. We did other immunomarkers, but the pictures did not look very nice, so I did not include them. So the diagnosis came out as a complex fibroadenoma with intraadenomatous DCIS intermediate grade, and the resection margins were free and no invasive component was found.
Our take-home message for radiologist: when to biopsy a fibroadenoma, increased in size in follow-up studies, but significant increase more than 20%. Recently palpable in old age, even with typical criteria, irregular outlines, high vascularity, microcalcifications, and cystic leaks.
As for the pathologists, fibroadenomas can harbor atypia, DCIS, or invasive carcinomas, so do examine them at high power. Don't just go scroll them in low power. The incidence of a carcinoma evolving in a fibroadenoma is very, very low, 0.002 to 0.125, in which 20% of these prove to be DCIS. It can be an extension from a tumor outside or not. It can just occur in the fibroadenoma and there's nothing outside. Do more than 1 myoepithelial stains, and that's what we do usually, and that's what we every pathologist always recommend. Do more than 1 myoepithelial stain. Examine the breast tissue around the fibroadenoma. You might find something interesting like a tumor or DCIS. The average age for these carcinomas as reported in the literature is in the 5th decade, but the cases we had are much younger. They're 35 and 45, and they're much younger than that. So it's pretty interesting to study. Thank you very much.
Thank you, Dr. Maha and Dr. Amira.
Thank you.
Any questions?
Yeah, thank you. Fantastic cases. just on the last one, did you do EEC adherent to exclude lobular neoplasia? It just looked very monotonous, a bit discohesive. Yeah.
It did not look discohesive to us. Maybe the pictures, or I don't know, but we did not have that suspicion, خالص.
Right. It's just generally to be on the safe side if you have a fully solid proliferation. Particularly looked like it has some pagetoid spread as well, with some residual positive.
Well, after hearing your lecture today, I think we'll think about doing that in every case.
You wouldn't lose anything.
Yes.
It's just to confirm
exactly.
in case, because sometimes it can be they look very similar. Very difficult to tell sometimes morphologically.
Yes, thank you.
Okay, thank you. The next presenters, Doctor. Okay, the last talk. The presenters, Dr. Hazem Abdulazim and Dr. Ghada Hamid. Dr. Hazem is a lecturer of pathology in NCI Cairo University, and Dr. Ghada from radiodiagnosis, assistant lecturer of radiology NCI Cairo University.
جود ايفنينج قبل ما نقول جود نايت يعني خلاص احنا جايين اخر اليوم. احب اشكر كل الزمايل المتواجدين، واحب اشكر صراحه البرايمري بريست فاسكولار نيوبلازم ان هم خلونا نتجمع النهارده مع بعض، واشوف اساتذتي دكتوره ناديه مختار، دكتوره اماني، دكتوره غاده، دكتوره حبيبه، دكتور هشام، وطبعا دكتوره عبير، وكل زمايلي اللي موجودين. احنا في اخر اليوم هنستأذن بس حضراتكم، مش هنطول عليكم خالص، الموضوع هيبقى بريف جدا، مش هناخد الوقت، مش هناخد نص الوقت حتى اللي موجود ده. نتمنى ان شاء الله ان كلكم تستفيدوا منه، وحاجه مش كومن قوي موجوده بنلاقيها كل يوم، ولكن to be mentioned. دكتوره غاده زميلتي.
اهلا وسهلا، انا غاده حامد، مدرس في معهد القومي للاورام واخصائي الاشعه التشخيصيه والتداخليه في مستشفى بهيه. دكتور حازم هيكون معانا في اول برزنتيشن.
Vascular lesions are uncommonly encountered in the breast. They represent a spectrum of benign, atypical, and malignant entities. According to WHO classification of breast tumors, vascular lesions of the breast include hemangiomas, angiomatosis, atypical vascular lesions, primary angiosarcoma, and post-radiation angiosarcoma. It's a diagnostic challenge, of course. There is significant overlap in morphological features between vascular lesions of the breast and their non-vascular mimics. Also, benign vascular lesions may not be easily differentiated from their malignant counterparts, especially in the core biopsy settings, resulting in diagnostic dilemma. Hence the role of MDT. Good clinical, radiological, and pathological correlation is the best way to overcome this diagnostic dilemma. As we see here, to reach the diagnosis, first clinical, second radiological, and the gold standard is histopathological. Spectrum of diagnosis at Bahia Center. Different entities of vascular neoplasm were diagnosed at Bahia Center. We are starting here by benign hemangiomas and lymphangiomas. Two types of hemangiomas are encountered, perilobular hemangioma and non-perilobular hemangioma. Both entities are seen incidentally in the specimen of other associated malignancies, not excised by itself, as it can be easily detected in the radiological settings, and they are less than 2 centimeters, so it's not worrisome for radiologists. Second, atypical vascular lesions, first described by Feinberg and Rosen in 1994. Defined as an atypical vascular proliferation on previously irradiated breast skin. Two types are for atypical vascular lesions, lymphatic type and vascular type. The vast majority of atypical vascular lesions have a benign clinical course. Rare cases may have local recurrence, hence its clinical significance, and even progress to angiosarcoma. Some authors consider atypical vascular lesions as a precursor for angiosarcoma. Complete excision and follow-up is a treatment modality. About malignant vascular tumor, which is the ghost in the box in our practice for vascular lesions, post-radiation angiosarcoma much more seen than primary angiosarcomas. Post-radiation angiosarcoma incidence very low, 0.09 or 0.60%, occurs in skin of chest wall or scar residual breast tissue after radiation. Primary angiosarcomas are rare vascular neoplasms, arise in younger patient ages and subdivided into low, intermediate, and high grades based on the pattern of growth and other histologic features.
Our case presentation today is about 35-year-old lactating female presented with 2 months history of enlarging painful right breast lump with negative family history of breast cancer. Mammography revealed huge right breast dense mass replacing almost the whole breast parenchyma. Complementary ultrasound revealed right breast heterogeneous hypervascular mass lesion with lobulated rather defined margins. No evidence of chest wall invasion, no regional lymphadenopathy with unremarkable left breast study. Considering the patient's complaint and the clinical presentation, phylloides tumor was suggested for histopathological correlation. True cut biopsy revealed entirely hemorrhagic material with no evidence of breast tissue. The material considered non-representative and rebiopsy was recommended. The right breast lesion, clinically, the right breast lesion showed rapidly progressive enlargement with ulceration of the chest overlying skin and marked drop of the hemoglobin levels, which necessitates multiple blood transfusion within a short time. Clinical presentation required further assessment. Urgent MRI of the breast with contrast revealed right breast, huge heterogeneous solid lesion with multiple cystic spaces within, assuming heterogeneous signal intensity in T2 and STIR. Peripheral nodular enhancement with centripetal filling in post-contrast series was suggestive of vascular tumor. Right hepatic lobe focal lesions are seen attaining the same signal intensity as that of the right breast, warranting further metastatic workup. The possibilities for this vascular tumor includes huge breast hemangioma with giant hepatic hemangiomas. Another differential angiosarcoma of the breast with metastatic vascular hepatic focal lesions. Metastatic workup CT chest abdomen pelvis revealed. Right breast huge mass with triphasic liver study revealed. Right breast huge mass showing intense peripheral enhancement with centripetal filling on the delayed phases. A giant right hepatic lobe well-defined hepatic focal lesion showing peripheral enhancement on the arterial and portal phases with more filling on the delayed phase. Similar smaller adjacent lesion was also detected. The MDT decision was guided by the rapid progressive disease of the patient within a short time. I think it was 1 month duration. She underwent simple mastectomy after we got a consent. Also, the lack of histopathological evidence of being malignant lesion.
As said by Dr. Ghada, the MDT decision didn't wait for the second biopsy. In this concern, the clinical pathological and radiological correlation is mandatory. So we proceed to a simple mastectomy. As we see here in these pictures, the mass is ulcerating, occupying the whole breast with narrow deep margin. Cut section is extensively hemorrhagic and fleshy. This is by gross microscopic picture. As we see here, there is multilobulated infiltrating highly vascular mass in this concern with perineural invasion and infiltration of the soft tissue. Higher power showing this anastomosing vascular channels, no solid areas, no sarcomatous, frank sarcomatous areas. These vascular spaces are filled by RPCs, not well formed. There is scaffolding, there is no necrosis. The higher power showing the ugly face of these cells, showing hyperchromesia, increased NC ratio, increased mitosis, and other malignant features. We proceeded to immunohistochemistry to confirm our diagnosis of angiosarcoma. We did CD34, which was diffusely positive. CD34 may be positive in other breast lesions, so we confirmed it by CD31, specific for vascular angiosarcoma. and we do a Ki-67, which was high, reaching more than 20%. The case was diagnosed as moderately differentiated angiosarcoma of the breast. Angiosarcomas of the breast are rare malignant tumors that arise from endothelial cells lining vascular channels. Primary angiosarcomas of the breast occur sporadic in young women and usually present as palpable mass and account for 0.04% of all malignancy of breast tumors. Secondary angiosarcomas occurs more frequently after radiotherapy with latency period 5 to 6 years. The grading is very important for pathologists. The grading of angiosarcoma is the most important prognostic factor, as low grade differs from intermediate and high grades. High grade lesions have frankly sarcomatous areas as well as areas of necrosis, hemorrhage, and infarction. The large size of this specimen needs more and more sections to allow to identify any high grade areas. Multiple grades may exist in the same tumor, so thorough examination of all sections is mandatory.
The prognosis for patients with primary angiosarcoma depends on the tumor grade. Metastases occur most frequently to bone, lungs, and liver. Metastases to the contralateral breast also have been reported. Sonomammography appearance of the angiosarcoma is non-specific. PET with 18-fluorodeoxyglucose may be used for staging of angiosarcoma. MRI is helpful in determining tumor extent and in planning surgery. It also may detect a residual disease after incisional biopsy. Conclusion: primary and secondary angiosarcomas of the breast are rare. Both are manifest with skin discoloration, skin plaques, nodules, and a palpable mass, or a combination of these signs. Mammographic findings are non-specific to angiosarcoma. Sonographically, angiosarcoma may present as heterogeneous hyperechoic hypervascular mass that is associated with disruption of the normal breast architecture. MRI may be used to determine the lesion extent, as said before. Okay,
and the gold standard is pathology.
Thank you. Thank you.
Thank you. Thank you, Dr. Hazem and Dr. Ghada.
عملت دي 240
لا ما عملناش 240 هي كانت فول ار بي سيز فهي مش شكل الفانجيوساركوما.
Any questions? Okay, thank you. Thank you so much.
Thank you for your interest and your listening and your attention. And this is the end of our session for today.